Hello, my name is Phil Pereira, and I'm the Emergency Ultrasound Co-Director at the LA County USC Medical Center in Los Angeles, California. And welcome to Sound Bites. In this module, entitled Introduction to Bedside OBGYN Ultrasound, we'll focus on the bedside examination of the uterus. We'll begin by reviewing the female pelvic anatomy that's important to know to perform ultrasound of these structures in the emergency department. Then we'll move on to a discussion of both the transabdominal and transvaginal approaches for investigating the pelvic organs. Again, in this module, we'll specifically look at the uterus. We'll introduce normal and abnormal ultrasound findings of the uterus, and in Module 2, the adnexa. Let's now review the OBGYN anatomy that we'll need to know to perform bedside ultrasound of this structure. We see the lower part of the uterus, the cervix, the intermediate body, and the upper fundal region of the uterus where we define an intrauterine pregnancy to be located. We see the region where the fallopian tube enters into the uterus, which is known as the interstitial region of the uterus in a normal uterus, and the corneal region of the uterus in a bicornuate uterus. We see the parts of the fallopian tube, the proximal isthmal, the ambulary portion of the fallopian tube, which comprises the majority of the region of the tube, and the distal infundibular region of the fallopian tube. We also see the broad ligament that encases both the fallopian tube and the ovary. Thus, the ovary can be relatively mobile and can be found in different locations within the female pelvis with regard to the uterus. Now let's move on to the differences between transabdominal versus transvaginal ultrasound for investigation of pathology or an intrauterine pregnancy of the uterus. Here we see the benefits of transabdominal ultrasound to the left and transvaginal ultrasound to the right. For transabdominal ultrasound, we'll be using a 3 MHz general abdominal probe, a lower frequency than we'll be using for the transvaginal ultrasound approach. Usually for transvaginal ultrasound, we'll be using an 8 MHz endocavitary probe that cycles at a higher frequency than the general abdominal probe. In terms of our bladder preparation, we're going to want a full bladder for transabdominal sonography, as a full bladder is our acoustic window onto the female pelvis. For transvaginal ultrasound, we want to empty the bladder, as a full bladder pushes the uterus into retroflexion, making it much harder to see on transvaginal ultrasound. Thus, it's really important to have our patients void before the exam. In terms of the scanning field, on transabdominal sonography, we're going to have a wider scanning field with less general resolution. In comparison, on transvaginal ultrasound, we're going to have a narrow field of scanning, but we're going to have increased resolution. Thus, the two approaches are very much complementary, and we'll generally want to begin with the transabdominal approach to get that wider field of view before moving in to perform a transvaginal approach for more resolution on the case. In terms of pregnancies, we'll be able to see a gestation at a little later time during the pregnancy cycle with transabdominal approach versus a little earlier versus transvaginal approach. This is Dr. Hamashi Pereira, a current OBGYN resident at the New York Presbyterian Hospital in New York City, showing the correct placement for the probe for the long axis technique of transabdominal sonography using a phantom or simulation type equipment. Notice the probe marker is oriented towards the patient's head, and we're scanning from side to side along the uterus. Now let's look at an image on how the transabdominal ultrasound view will appear both pictorially and on the ultrasound screen. Remember that for the transabdominal approach, using a long axis or sagittal view, the probe marker should be aimed superiorly towards the patient's head. As seen to the pictorial to the left, we want to have a full bladder to perform an optimal exam, as a full bladder is going to be our acoustic window onto the female pelvis. We see the full bladder anteriorly and the uterus just posterior to the full bladder in the pictorial to the left. In the resulting ultrasound image to the right, we see the bladder, which will be a darker anechoic fluid collection, immediately anterior to the uterus, which we'll see immediately posterior to the bladder. Here's the resulting ultrasound image as taken from the transabdominal long axis or sagittal cut through the female pelvis. Remember that we have the probe marker oriented towards the patient's head, therefore superior will be towards the left of the screen, inferior to the right. anterior to the top of the screen, and posterior down all the way to the bottom of the ultrasound screen. We see the bladder, the large anechoic structure to the top of the screen, and then we see the parts of the uterus, the fundus, the top part of the uterus to the left, the cervical region of the uterus to the right, and right below the pelvis, we actually can see there, in the area behind the uterus, the cul-de-sac, the potential space where fluid can build up in the female pelvis. Here's another image is taken from the transabdominal long axis or sagittal view through the female pelvis. Again, superior to the left, inferior to the right, anterior to the top, and posterior all the way to the bottom of the ultrasound screen. Again, we see a distended bladder facilitating our ultrasound view from the transabdominal approach, the fundal region of the uterus to the left, cervix to the right, and we can see the endometrial stripe, that white line going from fundus down to cervix. In this video clip, we appreciate a slightly different orientation of the female pelvis. We note here the bladder, inferiorly located to the uterus, which we see superior or towards the left. We note here that the uterus is located such that the fundal region is more anterior than the cervix, which here is located more posterior. But let's look into the pelvic cul-de-sac, that potential space, and what we see here is an area of darker anechoic fluid which is collected just posterior to the cervix. Next, we're going to swivel the probe, so the probe marker is located over towards the patient's right side, so now the probe is sitting in a transverse or short axis orientation over the female pelvis. Notice here that we're swiveling the probe up and down, cutting through the female pelvis in the short axis orientation, and looking all the way from fundus down to cervix. Here's an illustration showing what the structures will look like as taken from the transabdominal approach short axis or transverse view. Remember that the probe marker will be aimed over towards the patient's right side to make the short axis or transverse view of the female pelvis. Again, we'll see the distended bladder anteriorly, and just posterior to the bladder we'll see the uterus. Now, because we're in cross-section here, we can actually investigate the adnexa by swiveling the probe from side to side. We see the resulting ultrasound image to the right, and again we see the large dark anechoic fluid collection, which is the bladder anteriorly, and just posterior to the bladder we see the uterus. Here's an ultrasound image of the female uterus as taken from a transabdominal approach using a short axis or transverse cut through the pelvis. We see here that the probe marker is located over towards the patient's right side, so right is to the left of the screen and left is to the right. We see the bladder, the darker anechoic fluid collection, anterior to the uterus, which we see located directly posterior to the bladder. We can see the white area of the endometrial stripe in the interior of the uterus, and just posterior to the uterus we can see that potential space, the pelvic cul-de-sac. Here's another video clip showing a short axis or transverse view through the female pelvis. This time the bladder is a bit more distended, giving a better acoustic window onto the uterus. Again, the probe marker is over towards the patient's right side, so we see the right side of the uterus over towards the left of the ultrasound screen. We see the darker anechoic fluid collection, which is the bladder, and again we see the uterus just posterior to the bladder and the white endometrial stripe located at the midline of the uterus. We also see that potential space, the pelvic cul-de-sac, just posterior to the uterus. Now let's turn our attention to performance of the transvaginal ultrasound exam. For this exam, an optimal imaging of the uterus and adnexa will need an endocavitary probe, as shown as the images here at the top of the slide. This probe will cycle at a higher frequency than the probe used for transabdominal sonography, cycling around 6 to 8 megahertz of frequency. We'll prepare our probe by using a sheath with ultrasound gel inside and Surgilube on the outside of the sheath as less irritating for our patients. After each use, we'll clean the probe with a CaviWipe and then place in a Sidex cleaning solution. Here's the endocavitary probe that we'll be using for the GYN exam. Notice that it has a slight curve to the tip, and we'll use that curve to best visualize the adnexa and structures on GYN ultrasound. I'm pointing here to the notch in the top of the probe that is the indicator or marker dot on the probe, and that'll match us to the indicator dot on the ultrasound screen. Notice we also have a sheath on the probe, and that's standard for GYN sonography. Remember that the probe must be thoroughly cleaned in between different patients as well. We'll begin here by inserting the probe in a long axis configuration. Notice here the probe marker is now towards the ceiling. We're using some simulation equipment here that allows us to simulate using GYN phantoms for ultrasonography. We'll begin by visualizing the cervix, and notice that the hand needs to come very high up in a vertical plane to visualize the cervix as it's more posterior. To visualize the fundus, drop your hand, bringing the tip of the probe more anterior to visualize the fundus in most women. Once you've come into plane with the fundus, you'll need to slide from side to side to visualize best all the way through the endometrial stripe out to the outer margins of the uterus, to make sure to fully inspect the uterus for any signs of pathology or a small pregnancy. Here's two illustrations showing what the anatomical structures will look like using the transvaginal approach long axis or sagittal cut through the female pelvis. In this orientation, the probe marker here is located up towards the ceiling. Notice here that the tip of the probe is located more anteriorly to better image the fundal region or top part of the female uterus. We can see here the bladder immediately anterior there to the female uterus, and recall that for this examination we want to have a completely evacuated bladder, a small bladder, so as best to image the female uterus. We see the resulting ultrasound image to the right. Notice that we have a better cut looking through the top part of the uterus, i.e. the fundus, and we can see the endometrial stripe, that white line arching down from fundus towards cervix. Here's a typical ultrasound image as taken from the sagittal or long axis view through the female uterus. Again, we have the probe angled slightly anteriorly here so that we're imaging best through the fundal region or the top part of the uterus. Thus, anterior is towards the top of the screen, posterior towards the bottom, superior towards the patient's head to the left, inferior to the right. We see the fundal region, the top part of the uterus to the left, and the lower cervical region to the right. Notice the endometrial stripe, the white line arching from fundus down to cervix through the midline of the uterus, and the potential space, the pelvic cul-de-sac, where fluid can accumulate within the female pelvis, directly posterior there to the female uterus. Notice here that we fail to appreciate any dark or anechoic fluid collections in the pelvic cul-de-sac. Let's take a look at another uterus as taken from a sagittal or long axis cut through the female pelvis. Remember that the superior aspect of the uterus is located to the left, inferior to the right. We see the fundal region to the left and the cervical region to the right. Notice here that this patient has a thickened endometrial stripe, and we can see the thickening of the white line arching from the fundal region down to the cervix, indicating that this patient is in a later stage of the menstrual period. Here's another ultrasound image showing a long axis scan through a female uterus in a patient who had recently undergone a voluntary termination of pregnancy, or a VTOP. Our patient had experienced continued bleeding after the procedure, and note here the very thickened endometrial stripe greater than 2 centimeters in diameter. Very suspicious for retained products of conception as a cause of our patient's continued bleeding. This patient had a GYN consult, and a D&C procedure was necessary to fully evacuate the endometrium of any retained products. Emphasizing the point that it's very important to have our patients completely void before performing transvaginal sonography, we see here a very distended bladder as taken from the transvaginal approach. We see the large, dark or anechoic fluid collection, which is the bladder, anterior located to the uterus, and notice here that it pushes the uterus into retroflexion away from the probe, giving a very bad image of the uterus. It's really difficult to discern all the different parts of the uterus from this view. Having the patient go and completely void in the bathroom, now we can return to the examination and get a much better image through the female pelvis. Now we can fully investigate all the parts of the female uterus, and we see here the fundus as located towards the left and the cervix towards the right. And we can also well delineate the endometrial stripe, that white line coursing from left to right from fundus all the way down to cervix. From the transvaginal approach long axis or sagittal view of the female pelvis, the second probe position should be with the probe aimed more posteriorly down towards the cervix. Notice here the image to the left shows the probe with the marker dot up towards the ceiling aimed down towards the cervical region of the uterus. This will give better imaging of the lower portion, the cervix of the female uterus, allowing you to better inspect that area for possible pathology and or a pregnancy. And we can see the resulting ultrasound image to the right, best showing the cervix as located there in the ultrasound image. Here's a resulting ultrasound image as taken from a transvaginal approach long axis or sagittal view through the female uterus. And we see the two portions of the cervix well seen on bedside sonography in the middle of the image here. Now notice as I swing the probe more anteriorly, I'm going to bring the fundal region of the uterus into view. So if I angle the probe more posteriorly, there I have cervix, and more anteriorly, or dropping my hand, as I'm doing now, I'll best bring the fundal region of the uterus into the ultrasound image. So again, cervix, down to fundus, dropping my hand and orienting the probe more anteriorly so it's going to best image through the top part of the uterus. It's important to image all parts of the uterus as it can be difficult to get the whole uterus onto the ultrasound screen from one slice. Here's another ultrasound image where we're again beginning with the imaging of the female uterus at the cervical region with our hand in an upright position and the probe aimed posteriorly. Notice here that we're going to now lower our hand, drop our hand, and point the tip of the probe more anteriorly, and there's the fundal region coming into view. So just remember that you're in the vertical plane. Having your hand up high will aim the probe posterior to image cervix, and dropping your hand and aiming the probe more anterior will best image the fundal region. Now we also need to visualize the uterus in a second plane. Here we'll rotate the probe into short axis by moving the probe marker towards the patient's right side. Now we're cutting the uterus in cross section. So once we've found the fundus on short axis, we'll scan up and down in a vertical plane, looking all the way through that uterus in cross section to make sure that we've fully inspected for any pathology or, again, a small pregnancy. It's important to image body structures in two planes, and the female uterus is no exception to this general rule. Here we're using the transvaginal approach, looking from the short axis or coronal cut through the uterus. And we can see here that now we have the probe in a side-to-side orientation with the probe marker over towards the patient's right side. We're imaging now in an upright position, so the probe is oriented more anteriorly to best image through the upper part, the fundal region of the uterus. And we can see the resulting ultrasound image to the right with the endometrial stripe in the midline of the uterus. To fully image through the uterus in the short axis or coronal plane, we must elevate our hand and aim the probe more posteriorly so that we're imaging down towards the female cervix. And as we can see here, now we've oriented the probe in a more down position so that the tip of the probe is located more posteriorly down towards the cervix. And we can see again the resulting ultrasound image to the right with the endometrial stripe in the midline and the uterus cut in cross section. This cut will be at a lower area or slice through the female uterus. Here's a resulting ultrasound image as taken in a coronal or short axis view. What we see here is that we have the probe marker over towards the patient's right, so right will be to the left of the screen and left will be to right, anterior towards the top of the screen and posterior all the way down towards the bottom. We can see the uterus cut in cross section with the endometrial stripe in the midline of the uterus. We see the potential space, the pelvic cul-de-sac, just posterior to the uterus there. Notice here, we failed to appreciate any anechoic or dark fluid collections within the pelvic cul-de-sac. Here's another clip showing a uterus cut in cross-section from the coronal or transverse axis of the female pelvis. We have the right side of the uterus as cut in cross-section over towards the marker dot towards the left of the screen. Therefore, the left portion of the uterus will be towards the right of the screen. We appreciate the endometrial stripe, the white line in the midline of the uterus as seen towards the middle part, and we can see the potential space, the pelvic cul-de-sac, where fluid can accumulate just posterior to the uterus. Notice here the absence of any significant fluid. Because there's a wide variation in normal uterine positions within individual ladies, it can be difficult at times to find the uterus on bedside sonography. Let's look first at a retroflexed uterus in the image from Dr. Frank Netter's Textbook of Human Anatomy, as shown here to the upper left. Notice the retroflexed uterus. We have the cervix in the normal position, but that the fundus of the uterus flops posteriorly. Thus, we may need to orient our hand in a more upright position to aim the tip of the probe more posteriorly to see the uterine fundus in the retroflexed uterus. Now let's compare that to the antiflexed uterus as shown in the image to the bottom. Notice here the fundus of the uterus flops anteriorly as opposed to the normal uterus. In this configuration, we may need to drop our hand and aim the tip of the probe more anteriorly to see the fundus of the uterus. Now, making the situation even more interesting, if you will, there's even further variation in normal uterine positions as we can have progressive degrees of retroversion as shown here in another nice image from Dr. Frank Netter's Textbook of Human Anatomy. We can see here the normal uterus as shown here flopping anteriorly over the dome of the bladder, but notice the progressive degrees of retroversion in the uteri as detailed there. Notice that the fundus of the uterus becomes more posteriorly oriented in a more retroverted uterus. Again, this would mean that on transvaginal sonography, you would need to have your hand oriented more upright and aim the tip of the probe more posteriorly to see the fundus of the uterus. Here's a video clip showing the normal orientation of the uterus in a transvaginal sagittal or long axis configuration. Here we'll see the typical appearance of the uterus with the fundal region to the left and the cervix is located over towards the right. We can see the endometrial stripe, in this case a thickened endometrial stripe, arching from the fundal region to the top of the uterus, inferiorly down towards the cervix as seen here towards the right of the image. So in most patients, this will be the typical configuration of the uterus that we'll appreciate. However, let's take a look at this uterus. And what we see here is that this uterus has a different orientation than in the last video clip. We appreciate here that the cervix is located more anteriorly here, and that the fundal region flops posteriorly there, almost on top of the uterus. So we have cervix to the left and fundus to the right, with the endometrial stripe arching in between the two structures. This is the typical appearance of a retroflexed uterus in a long axis or sagittal configuration. Here's another retroflexed uterus as taken in the long axis or sagittal scan view. We see here the cervix to the left again, and notice that the fundus is flopped posteriorly there on top of the cervix, and the endometrial stripe arches from left to right here, in variance to the normal orientation of the uterus, which we appreciated in the video clip earlier. Next, let's take a look at an antiflexed uterus as taken from a long axis or sagittal plane. We see here superior to the left of the screen, inferior to the right, anterior to the top of the screen, and posterior all the way down to the bottom. The first structure that we identify is the cervix, located to the top of the screen anteriorly. We see the fundus all the way down to the bottom there. Notice that the endometrial stripe takes a zigzag appearance to connect the cervix to the fundus, as the fundus flops anteriorly on top of the cervix in this antiflexed uterus. Adding to the variability in female human anatomy is the fact that there are a proportion of women who have a bicornuate uterus. The bicornuate uterus, as pictured here in this illustration, is a result of a congenital developmental abnormality of the uterus with a division of the superior uterine fundus by a septum. And what can occur is that patients can have anything from a complete bicornuate, where the septum comes almost down to the cervix, to an incomplete bicornuate, where there's only a small division of the septum into the uterus. Here's a bicornuate uterus as shown in a transvaginal short axis plane. I'm scanning from the bottom of the uterus towards the cervix up towards the top, and I have the probe indicated towards the right. As we go from the bottom as shown there and advance towards the top, we can see separation of the endometrial stripe into two limbs that make up the two cornea of the bicornuate uterus. Again, we're scanning from the bottom towards the top, and we see the two cornea with two areas of thickened endometrial stripe. And what's interesting in this patient is that she actually had a positive urine pregnancy test. We're going to still the image down and now look further at this bicornuate uterus. We can see the right corneal limb and the left corneal limb, and we can see the midline septum extending down towards the middle and dividing the corneal limb in the bicornuate uterus. But let's look further at the right corneal limb, and what we see here is the gestational sac of an early pregnancy within the right corneal limb. Unfortunately, pregnancies within a bicornuate uterus can be problematic if the implantation is high within the corneal limb. This is considered a corneal ectopic pregnancy, a variant of ectopic pregnancy even within the uterus, defined by a thin endomyometrial mantle. Next, let's look at the same uterus, the patient who was pregnant with a bicornuate uterus, from the long axis configuration. Here's a still image of that same ultrasound. I'm going to begin by showing with a small indicator arrow the confines of the thickened endometrial stripe going up the right corneal limb. And you can see here that the endometrial stripe is very thickened, consistent with the pregnancy in this patient. Now let's look at the gestational sac again, the area, the dark area there, towards the top of the right corneal limb. Now let's put this into actual video play, and as I scan from the right side to the left side, we can actually see there's the right corneal limb going up the side of the uterus over towards the left, and we can see the left corneal limb going up the leftward part of the uterus. Let's conclude our discussion of OBGYN sonography of the uterus with a discussion of free fluid within the pelvis. As we've remarked about earlier in the module, fluid will appear dark or anechoic on ultrasound. We'll be measuring the free fluid behind the uterus in the pelvic cul-de-sac, and traditionally that's taken in a long axis or sagittal plane. Most OBGYNs use the rule of thirds to determine the amount of free fluid within the cul-de-sac. A small amount of fluid, as shown in the image to the upper right here, is tracking less than 1/3 down the posterior wall of the uterus in the cul-de-sac. A moderate amount of fluid will be tracking between 1/3 and 2/3 the posterior wall of the uterus, and a large amount of free fluid is defined as greater than 2/3 the posterior wall of the uterus are flowing into the peritoneal cavity. Also, a positive Morrison's pouch right upper quadrant hepatorenal exam can be seen with a large amount of free fluid. Here's a video clip showing a small amount of fluid, again taken in the long axis or sagittal configuration from a transvaginal approach. We see the uterus here in a long axis plane, fundus to the left, cervix to the right, and a small amount of darker anechoic free fluid located just posterior to the uterus in the pelvic cul-de-sac. And we can see here that this is tracking less than 1/3 up the posterior wall of the uterus, thus defined as less than 1/3 or a small amount of free fluid. In the next step, we'll orient the probe in a short axis configuration. So now we're cutting the uterus in cross section. And what we see is the uterus with the endometrial stripe in the midline of the uterus and that small amount of free fluid just posterior to the uterus in the pelvic cul-de-sac. Notice again that it's a small ball, therefore indicating a small amount of free fluid. Let's contrast those last video clips with this one. This one was from a patient who had a positive ICON or positive pregnancy test and who presented with vaginal bleeding. And what we see here is the uterus in long axis view, and we see a large amount of free fluid tracking up the back wall of the uterus. And we can see here a metallic foreign body within the uterus. Interestingly enough, that's an intrauterine device, an IUD, in this patient who had a positive pregnancy test. So unfortunately, this patient had a ruptured ectopic pregnancy, and all that free fluid is blood tracking into the pelvic cul-de-sac. So a moderate to large amount of free fluid in that patient with a ruptured ectopic pregnancy. Here's another patient who had a ruptured ectopic pregnancy. What we see here is the uterus again in a long axis or sagittal plane. Notice the large amount of free fluid tracking both posteriorly in the pelvic cul-de-sac and flowing anteriorly there around the dome of the uterus to lie to the top portion of the ultrasound image. So a large amount of free fluid in another patient who had a ruptured ectopic pregnancy. Finally, let's take a look at a video clip from a patient who presented with a increasing abdominal swelling and girth and a negative ICON or negative urine pregnancy test. What we see here is the uterus in a long axis or sagittal view. Notice the small orientation or amount of uterus here in relation to the huge amount of free fluid that flows from the posterior cul-de-sac all the way the dome of the uterus to flow anteriorly there to the uterus as well. Unfortunately, this patient was later diagnosed with ovarian cancer, and all of this fluid was ascites that had built up from the pathology within the ovary, but a huge amount of free fluid on transvaginal long axis or sagittal scan, almost dwarfing the uterus in its proportion. Free fluid may at times be difficult to find on transvaginal sonography, and we may need to orient the probe as to image all the way from fundus to cervix as shown in this video clip. There's the fundus there, and notice as we lift our hand and aim the probe more posteriorly, we image the cervix, and there we see a small amount of free fluid just posterior to the cervix. Notice that we could have easily missed this amount of free fluid if we had only looked at the fundal region of the uterus. Thus, it's very important to inspect all the way from fundus to cervix for any pathology within the uterus and also any free fluid within the pelvic cul-de-sac posterior to the uterus. So in conclusion, I'm glad I could share with you part 1 of OBGYN ultrasound, focusing on the ultrasound of the uterus. This is a very helpful technique for the emergency physician in evaluating patients for pregnancy or other OBGYN conditions. And as we discussed, both transabdominal and transvaginal approaches can be very helpful and offer complementary data for the emergency physician. Now, the uterus may be positioned differently in women, as we went through in the module, and we may need to compensate the probe position to find the structure, either aiming the probe more anterior or posterior, or even to the right or left to find the uterus. So we'll return with OBGYN ultrasound part 2, focusing on the ultrasound of the adnexal structures.